guys, so today we're going to talk about nursing care of the child with a cardiovascular disorder.
Coarctation of the aorta, I want you guys to look at the fact that the aorta right there above the pulmonary artery is constricted, it's narrowed, it's smaller. This occurs in 6% of congenital heart disease patients, and it's three times more likely in males. What I want you to know about coarctation of the aorta is the amount of symptoms the child is going to exhibit depends on how narrowed the aorta is or the coarctation. So some children can grow up and be school-age kids before they even discover that they have this because they're in PE or they have to go through a physical for somebody finds it. When we do a health history and physical exam on these kids, we're going to see the same things that we've seen previously. Issues with irritability. Older children are going to have headaches, fainting, dizziness, leg pain with activity because they're just not getting the blood flow to those areas. It can also develop frequent nosebleeds. Those sorts of things might be test questions. We're going to assess their pulses in all four extremities, and what you might see is bounding pulses in the upper extremities and weak or absent pulses in the lower extremities. I want to do a 4-point blood pressure, meaning you're taking the blood pressure on all four extremities and charting what you got on which extremity. And you'll find that the blood pressure in the upper extremities might be 20 millimeters of mercury higher than the lower. Obviously not what we would expect. Might see that the child's chest has some notching at the rib cages, so you'll see it kind of dip in a little bit. You might hear a soft or moderate systolic murmur, and they state that it's most often heard at the base of the heart, either listening from the back or in the area of the left axilla. The next disease that is an obstructive disorder is pulmonary valvular stenosis. And this is this obstruction in the blood flow between the right ventricle and the pulmonary arteries. So this is narrowing of the pulmonary artery right above the valve, which is why it's pulmonary valvular stenosis. You can see in the picture it's pointing at the pulmonary artery and the little valve below it is kinked off or blocked. Children have a increased pressure in the right atrium because the blood's not being able to get out of the ventricle. So the atrium backs up, and this could lead to a reopening of the foramen ovale, which would allow deoxygenated blood to pass through to the left side of the heart, which we would not like because then you have a mixed circulatory defect. And on children with pulmonary valvular stenosis, these kids could be asymptomatic. They might only exhibit mild heart failure symptoms. If their stenosis of the valve is severe, then these children might be cyanotic. It is really important to get an accurate health history and do a physical exam that is full physical exam. These children might for age and only mild dyspnea or cyanosis with exertion. One thing that you will hear that might be a test question is a high-pitched click that follows S2. slide, we're looking at mixed disorders, which basically just means that we're mixing oxygenated and deoxygenated blood. This is a transposition of the great arteries and hypoplastic left heart syndrome. With a mixed defect, both of these patients will require prostaglandin E, the ductus open. We would like it to close in most children, but the children who have these sorts of defects, we need the ductus arteriosus to stay open until they're able to have surgical intervention. So these children end up having a lower oxygen content in their systemic blood flow. Their cardiac output's decreased, and then they develop heart failure. With transposition of the great vessels, literally the pulmonary artery and the aorta are in the wrong places, and they're going to the wrong places. So the aorta is coming off the right ventricle instead of the left. The pulmonary artery is coming off of the left ventricle instead of the right. These kids have to have a patent ductus arteriosus in order to survive until they're able to do surgery to fix this. These kids are going to have significant cyanotic episodes without any murmur. So a test question would be, which type of disorder has significant cyanosis without a murmur in the newborn period? And that is transposition of the great arteries. So it's poorly oxygenated blood goes back into the right atrium and ventricle, and then it gets pumped out through the aorta and back to the body. So it's blood that's not even very well oxygenated that's getting pumped back and forth out to the rest of our body. And then oxygenated blood is coming back to the lungs, to the wrong side of the heart, and then it's being sent to the lungs through the pulmonary artery. So the lungs are not getting good oxygenated blood. The body is getting poorly oxygenated blood. It is just a mess. So for a nursing assessment on these patients, we're going to see significant cyanosis. Like I said, no murmurs. Some babies will not develop the cyanotic episodes until they're a few days old because their PDA is open, and once they've gotten to a few days old, the PDA closes, and then the cyanosis rears its ugly head. So we give them the prostaglandin E to keep it open once we know that this is the case. We want to note when we do the health history and physical exam, when they had the onset of cyanosis, does it occur with feeding? Does it occur with crying? Are they becoming cyanotic while they're just laying there resting and sleeping? When we listen to the heart sounds, we're going to notice that the second heart sound is very loud. If the patient has already developed heart failure, there's likely going to be edema. We'll see facial edema, sacral edema, possibly leading to edema of the extremities. We'll see tachypnea, and we'll hear adventitious lung sounds. With hypoplastic left heart syndrome, it literally means that the left side of the heart is either not developed at all or is severely underdeveloped. This is the fourth most common congenital heart disease. The treatment options are palliative. If they're unable to have a cardiac transplant within the first few weeks of life, quite a few different surgeries throughout their life. It's not a one and done kind of fix. The right side of their heart works, and it works usually just fine. The issue is that the blood that comes back to the heart from the lungs has to go through the ASD to the right side and then pump to the lungs and the systemic system. through what the patent ductus arteriosus. So if there is no patent ductus arteriosus, if it's not open, then these kids just die, and they die pretty quickly. So we do have to give these children prostaglandin E as well to keep the patent ductus arteriosus open until they can have a transplant. Assessment after birth, these kids might be asymptomatic, literally just like the transposition of the great arteries, because the patent ductus arteriosus is still open. Once that closes, when the baby's a couple of days to a week old, then they're going to start exhibiting really bad cyanotic episodes. And then that leads to shock, and then emergent resuscitation, and then usually death. These children are going to be poor feeders. They're going to tire so easily. We're going to have to keep really good track of their vital signs, and we're going to see tachycardia, tachypnea, hypothermia. Their body just does not have what it needs to be able to maintain life. We're going to see increased work of breathing, leading to increased cyanosis. Their extremities are going to become more and more purple and pale. And they're going to have highly decreased oxygen saturation. There will be adventitious breath sounds. They may have a soft ejection murmur.